Fire department! Victim, victim, victim!
Thanks to our Access partners at Eagle Fire, we were able to collaborate in this high-speed live burn training. This multi-agency event included 3 full days of live burn evolutions and priority 1 trauma scenarios. We're talking 21 burns, 15 transports, 4 access agencies, and 1 Hanson medical director. This event was fun and effective. Big shout out to Captain Kelly Chad and Captain Tyler Osmus for planning and execution. Could this be the future of access training? Let's take a look at what made it such a success. This event combined the professional skills of firefighting and patient care. It brought the best in our providers' ability to showcase teamwork, communication, and skill development. Combined with stress inoculation, challenging scenarios, and no shortage of rapid decision-making. What we witnessed was enhanced patient care with a team approach to BLS and ALS care for critical burn patients. From dispatch and response to fire attack and rescue, and of course treatment and transport. Hot wash, rinse, alter scenario, and repeat. What were the areas of opportunity that we identified? The dynamic response of fire and EMS outside of our traditional block training. Can we use this as a catalyst for balancing online education and skills with more realistic hands-on scenarios? This was a great opportunity for some of our fire partners to practice medical care in the back of an ambulance for a critical patient. There lies an opportunity for fire to become more familiar with ambulance operation, equipment layout, and code 3 driving. ACP recommendations. Start by positioning the ambulance nearby with clear egress. After gurney removal, please close all doors to maintain the desired temperature. ACP personnel should respond wearing yellow vests as they make it easier for fire to identify and pass off patients coming out of the burning structure. For equipment, bring the gurney, scoop, X-series, and blue bags to a safe position that can be seen from the front door of the structure. Early in the event, either critical patient care or rehab may be needed. Fire will likely stage a medical equipment cache, which may become an untenable spot as the fireground situation evolves. Weigh the cost and benefit for early airway management in the front yard versus inside the ambulance. Inside the ambulance is temperature control and prevents an on-scene yard sale and equipment retrieval, while the front yard allows more space to operate around and resuscitate the critical patient. I tend to lean towards inside, but I also witnessed a masterful DSI in the front yard by Captain Meffin, Geisel, Snodgrass, Vernon, and others. Remember to practice safe gurney operations by riding low over unstable ground and keep hands on at all times. Then comes the decision tree. Weigh the option of fire riders and or a fire driver as the situation indicates. Remember, for ACP paramedics, the fire driver requires a post-call documentation via QR code. Turnouts and off-gassing. Turnouts should be left behind or placed in an external ambulance compartment. Remember to use the ambulance ventilation on the control panel. During those critical moments before transport, utilize your supervisors for priority 1 pre-alerts and obtain the Cyanokit from that supervisor. Now, a few words on decision-making in MCI scenarios for all access providers. Acknowledging the volatility of burned patients, they may require extensive interventions based on those injury patterns, maybe more than what we have on hand. In mass casualty incidents, or like a structure fire with multiple victims, the focus must shift to the most viable patients. After initiating resuscitative measures, evaluate efficacy and reassess signs of life. If there's no improvement, prioritization must move to the next patient, particularly when resources are limited. Approach to treatment. Quickly evaluate and address the life threats: airway patency and protection, inhalation injury, or polytrauma. Is drug-assisted airway management needed? This will also address pain management. Early teamwork and BLS care shall focus on the following: stop the burning process, remove clothing and jewelry, estimate total burn surface area using the rule of nines, keep warm and clean and as sterile as possible, early use of high flow tube and end tidal CO2, start an IV and administer pain medications. An IV can be obtained through burn tissue if needed, or otherwise consider an IO. Administer the Cyanokit for inhalation injury.
For a patient who has cyanide poisoning, a Cyanokit is crucial to a good outcome. With this, it includes early recognition of symptoms that indicate the patient does have cyanide poisoning, and then early administration. Our Cyanokits are kept on EMS 20, EMS 30, and Battalion 31. Therefore, if those units are not already on scene where the patient is, the recognition that we need to request them is crucial. Once the kit is on scene, mixing the medication together so that we can administer it is not a quick process. In the kit, which is in a Pelican case, there is the medication box. Each box comes with a card that has step-by-step instructions. There are also instructions on the back of the box, as well as the medication box itself. To mix, everything you need is already in this Pelican case kit. We will take a 250 ml normal saline bag and mix 200 mLs of that fluid into the Cyanokit. It is in a glass bottle, so being gentle with it is very careful so that we do not break it. Each medication box comes with a dual spike so that we can put our fluid into our medication bottle. Just like an IV bag, you're going to spike into the bottle as well as into the bag. You might have to use your muscles a little bit for this. Once our spike is connected to both the bag and the bottle, we are going to squeeze the fluid in until we get to the 200 ml mark. For each blue line, that indicates how much fluid we have already administered from the bag. While I do this, let's talk about cyanide poisoning in general. Cyanide poisoning is when any patient is in an enclosed space and exposed to smoke. The cyanide ions go into the mitochondria onto the production line where ATP is made. The cyanide ions prevent ATP production and therefore cause the body to go into anaerobic metabolism. When this happens, instead of ATP, lactic acid is produced. Lactic acid causes injury to all muscle groups, but especially the heart. Therefore, if we are not getting oxygen, our heart will go into cardiac dysrhythmias and eventually cardiac arrest. Cyanide poisoned patients can present okay initially at first, or seemingly so. They have a very compensated view of vitals. Their heart rate, blood pressure, and respiratory rate will be elevated. And then throughout time, usually with a quick progression, they will go unresponsive and potentially into cardiac arrest. Like I mentioned, this is not a quick mixing for this medication, so the earlier we recognize that we need it, the better, so that we have time to administer it before it is too late. Who can we give this medication to? Like I mentioned, any patient that has been exposed to smoke. So this includes pregnant patients. This also includes patients who are breastfeeding as long as the breast milk is discarded. At this time, there is not a pediatric recommended dose. If you find yourself in that situation where you have a pediatric patient suffering from cyanide poisoning, contact medical control to be advised as how to handle the situation. Once our 200 mLs are in the glass vial, we can take the bag of fluid off and take the stopper out as well. Each kit comes with its own drop set. You're going to spike the bottle just like you would a normal IV drop set line in a bag. If you notice, there is a green vent valve there. That valve needs to be open to allow this medication to correctly be administered. It is not a viscous medication, and it should flow through your IV line easily. In the event that your patient does not have IV access and all you have is an IO, no problem. Let's show you how we can work around that. This is a glass bottle and therefore cannot be pressure infused. So if you go to open up your IO drip and it does not drip freely like it should to administer medication, we're going to hang our bottle of medication so that gravity is our friend. From our IV kits, we will take a 3-way stopcock as well as the largest syringe that we can find, preferably a 60 ml syringe. If you attach your syringe to the third port of the 3-way stopcock between the IV drip set and the IO extension, you will turn the valve so that it closes off the IO extension. Once everything is connected, you can pull fluid from the bottle through the drip set until your syringe is full. This may not be a quick process due to the pressure that you have to flow medication through an IO. Don't worry about the timeliness of this procedure. It should take approximately 15 minutes for administration anyway. Once your syringe is full, you will turn the valve to where we can flow into the IO extension, and then you will slowly push the medication via syringe into the IO. If you have any questions about the Cyanokit or this protocol, you can ask a training captain or reference SWO R08.
Evaluate for polytrauma. If hypotensive, this is more likely the cause and not burn shock, which takes several hours to develop. Attempt to uncover any possible injury. Is there a pelvic fracture in need of a pelvic binder? Elevate that head 20 to 30 degrees is best practice to limit swelling and help managing airway to the triple axis position. A few words on airway. Dr. Irvin advises having a low threshold for airway management and be ready to move down the difficult airway algorithm, which may include a surgical airway when you cannot ventilate nor oxygenate. Pay particular attention to soot around the mouth, the nose, stridor, hoarseness, and shortness of breath. Post-intubation management. Confirm placement with end-tidal CO2 over 7 breaths. Use those X-series snapshots. Secure with a tube holder and a hard collar. The SIP collar is not advised as it obscures view of the anterior neck. Post-sedation. In the absence of a personal approach, the Advanced Airway course recommends alternating 50 micrograms of fentanyl with 5 milligrams of Versed in 5-minute intervals. Please use good clinical judgment for your patients in each circumstance, like age, fragility, comorbidities, shock index. Be aware that signs of under sedation could include tearing, bucking the tube, a curare clefter waveform, or even outbreathing your vent settings. Okay, let's transition over to the Zoll Z Vent. Start by taking it out and hooking up your oxygen. Next, go ahead and grab the vent circuit and make those connections. Don't hook up your test lung just yet. Come down here and go ahead and turn it on. And in this case, we'll say we have an intubated adult. Go ahead and select the adult button. What you'll get is a patient disconnect error. Now I'm going to go ahead and hold my hand over the end of the vent circuit for a breath or two. Until I get a high airway pressure alarm. This lets me know that the integrity of my circuit is good, as well as my connections. Now I can go ahead and grab the test lung and hook that up. That'll give me plenty of time to configure my settings. I'm going to grab the vent book. I'm going to look up the tidal volume and the recommended initial settings based off of the patient that I have. And then I'll come over here and I'll touch, turn, and confirm those settings. I want to allow a breath or two to go by on the test lung to make sure it's ventilating properly and it's not spitting out any alarms. Then I'll coordinate the movement over to my patient, and I'll come down here and I'll get an initial P-plat. The pat toe pressure in this case is 23.4. I'll note that and keep that as a baseline. Lastly, I'll keep a BVM and a push dose epi kit nearby in case this patient needs some type of troubleshooting or resuscitation. Continue to reassess your patient for changes. Use early and concise trauma radio reports, like the acronym MIVT: mechanism, injuries, vital signs, and treatments.
Trauma bay, and you're handing off the patient. You have 60 seconds of everybody's undivided attention.
All right, 34-year-old male involved in a house fire. We have approximately 20% burn surface area. Patient has been DSI'd. We've given 180 of sucks, 90 of ketamine. Patient does have a 7.0 tube and 22 at the teeth. Patient does have bilateral 18-gauge IVs established. We have also given roughly 500 of fluids. We have a Cyanokit started as well.
Being an EMS battalion chief on a fire incident is a critical role that integrates medical operations with the overall incident command structure. Let me walk you through the key responsibilities and how they unfold on the scene. First and foremost, integration into the incident command system, or ICS, is essential. I may serve as the medical branch director or medical group supervisor, working closely with the fire battalion chief and the incident commander to ensure our medical operations align with the overall incident objectives. Collaboration is the cornerstone of success here. One of my primary duties is triage and patient care coordination. I supervise EMS personnel as they perform triage, ensuring protocols are followed for everyone involved: firefighters, civilians, and other personnel. My job is to guide care priorities so that the most critical needs are met swiftly and effectively. Safety oversight is another critical aspect of my role. I constantly monitor the health and safety of our EMS teams and all responders on the scene, ensuring that safety protocols are upheld. When necessary, I may recommend firefighter rotation or rehabilitation to prevent overexertion and heat-related injuries. This is especially important during our hot Idaho summers when temperatures routinely climb above 100 degrees. In terms of resource management, I am responsible for assessing and allocating medical resources such as ambulances, supplies, and personnel. I also coordinate with hospitals and trauma centers to prepare for patient transfers and establish clear communication pathways. Speaking of rehabilitation, I establish and oversee firefighter rehab operations, ensuring firefighters have access to hydration, rest, and medical evaluations when needed. EMS personnel under my direction monitor vital signs and watch for any signs of stress, dehydration, or other medical issues among responders. When it comes to medical command and communications, I serve as the point of contact between EMS personnel and the incident command post for all medical operations. This involves relaying critical updates such as casualty numbers and resource needs directly to the incident commander. Patient transportation logistics also fall under my purview. I manage the seamless transfer of patients from the scene to medical facilities, working closely with both air and ground transport units, particularly for severe injuries. Post-incident, I take charge of documentation and reporting. I maintain detailed triage and transport decision records, resource utilization, and other key elements. These records are essential for compiling after-action reports to evaluate operations and identify areas for improvement. An equally important aspect of my role is training and mentorship. On scene, I provide guidance and support to EMS personnel, especially in high-stress situations. It's vital to ensure that all team members adhere to established medical protocols and standards. Finally, I also assist with public information support. By providing accurate medical updates to the public information officer and incident commander, I help ensure the media and the public are well informed about the medical aspects of the incident. In summary, the EMS battalion chief's role is multifaceted, combining leadership, medical expertise, and strategic coordination to ensure the safety, health, and well-being of all responders and patients on the scene.
Thanks to all that took part in this epic training. This was a heavy lift with many moving parts. We hope to do more trainings like this in the future, and we encourage you to challenge yourself when the stakes are low. We appreciate our Access partnership and the opportunity for reality-based training. We want to be dialed and perform when it really matters. Take care, my friends. Thanks for watching.
BSI, scene safe. Got alcohol prep pads, condiments, Tabasco, fork, scalpel. Let's go. Lubricate. Clean the area. Scalpel.
What's going on here, Boojak?
Oh, hey, Osmus.
Hey.
Well, ever since the live burn, I've just had Dr. Urban's sweet, sultry voice running through my mind all day, and I want to work on my advanced airway algorithm. You know, never miss a chance to get a rep.
Oh, sweet mother of Frankfurt. Okay. Yeah, not that way. Go ahead and remove the scalpel. Okay, let's go ahead and do this the right way.
Okay. Scalpel away.
All right. If we're really going to do this, let's do it right. So first off, we've got to identify our anatomy if we're going to go and crake someone, all right? We're going to look for that thyroid cartilage. It's usually right here, also known as an Adam's apple. Yeah, you've got a nice one right there. So go ahead and find that.
Okay.
All right, perfect. Next, now that we found the anatomy, we're going to make a small vertical incision. Right down the middle. Yep, perfect. Just like that. Great. Now let's go ahead and just do a little horizontal incision to make sure the opening is open.
Okay.
Good. Go ahead and stick your finger in there to confirm.
Okay.
Grab a straw.
Confirm.
We're going to breathe for this patient through the straw.
Okay.
Shove it in there and start breathing. Hey, Daisy, you want to jump in here too?
What are you guys doing?
I'm just working on some crikes, man, after the live burns and burn pages.
Dude. My patient.
Need some pepper.
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 Pepper.